Good morning. Deblina, you can start.
Sir, you can start.
This is a new part we've introduced in our academic program, that is surgical audit. As per NB regulations, every institution should have their surgical audit being discussed in this academic program. So we started this program with MR Hospital. Other district hospitals in West Bengal to please start this surgical audit. You can have this idea of how we are going to present the audit. So what you do is you either separate unit wise, or it can be comprehensive audit of the whole hospital for a month. So here in MR Bangur, we are doing the audit. We have 3 units functioning with 2 admission days and 2 OT days and Sunday by rotation. So we are presenting audit unit wise, and the idea of the audit is to assess to which surgical procedures or procedures are exposed, and what are the varieties of cases being admitted, what are the different surgeries being done. And the next part of this audit is to analyze how these patients are going in the post-op, anybody developing any post-op complications. And if there is a death, we does not have access to the post-mortem, but short of that, we can analyze the death based on our clinical progress. And then there are some situations where you learn something, whether this sort of death can be averted in subsequent situations. So I would request other district hospitals to give a thought and start this program of surgical audit in their practice. So today we will present the surgical audit of MR Bangur Hospital. It will start with Unit 1. Dr. Omkar Nath is a first-year junior resident, will present, and the bed in charge, Dr. Kuntol and Dr. Siddharth, will also there in the meeting. Okay, Omkar, you can share your screen and start.
Good morning, sir, seniors, and my dear friends. I am Dr. Omkar Nath, second year DNB PGT from Bangur Hospital, MR Bangur Hospital. Today I will present surgical audit for month of May under Unit 1 under Dr. Kuntal Chakravarti and Dr. Siddharth Misra. Summary: total OPD days 9, total admission days 10, and total OPD patient is 852. Total number of elective OT days is 9. Total time in OT 42 hours and 25 minutes. Total number of minor OT days 9. There is no mortality, and number of mortalities is 1. Now, admissions. Total elective admission was 20, among which 12 was male and 8 was female. Total emergency admission was 17, among which 11 was male and 6 female.
You need to split the male female. It is there in the screen. Just read the total.
Yes. Total elective operation is 17. Total emergency operation is 8. There was no mortality, and there was one morbidity. Now coming to the elective admission, two chronic calculus cholecystitis was admitted, in which one was male and one was female, for which laparoscopic cholecystectomy was done. 8 chronic calculus cholecystitis admitted, for which open cholecystectomy was done, and 3 inguinal hernia admitted, for which Lichtenstein mesh hernioplasty was done. 1 bilateral inguinal hernia was admitted, but patient was not fit for surgery, so OT cancelled. 2 acute cholecystitis admitted for which conservative management was done. One umbilical hernia was admitted for which retrorectus mesh hernioplasty was done, and 3 phimosis admitted for which circumcision was done. Coming to the emergency admissions, 1 gallstone pancreatitis admitted for which conservative management was done. 2 acute appendicitis for which open appendectomy done. 1 foreign body injection admitted, but OT cancelled due to difficult intubation. 2 Fournier's gangrene admitted for which debridement was done. 2 acute cholecystitis admitted for which conservative management was done. 3 patients admitted with head injury. 3 patients admitted with head injury for which conservative management was done. 1 perineal abscess admitted for which incision and drainage was done, and 1 palmar abscess admitted for which incision and drainage was done. 1 cellulitis admitted for which conservative management done, and 1 forearm abscess admitted for which incision and drainage done. 1 recurrent appendicitis for which open appendectomy was done, and 1 obstructive jaundice which was managed conservatively. Now coming to the minor operations, there was 11 excision of sebaceous cyst, 5 ZX procedure, and 8 incision and drainage, 6 granuloma excision done, and 4 intralesional triamcinolone acetate injection in case of ganglion. There was 1 morbidity and no mortality. Morbidity. 42-year female came in emergency with features of perforation, having free gas under right dome of diaphragm on X-ray erect abdomen, underwent exploratory laparotomy with Graham's patch repair. Patient was doing well up to POD4. On post-op day 5, first discharge was coming from the wound. First was sent for culture and sensitivity. It shows growth of streptococci. Regular dressing and proper antibiotics was given, but on POD10, wound dehiscence developed, which was further managed with regular dressing and debridement. On POD15, secondary suturing was done and patient discharged on POD17. Thank you.
This morbidity you are mentioning, you said wound dehiscence. How is the depth of dehiscence? Is it a skin dehiscence or it is a bust abdomen?
No, sir. It was skin and subcutaneous dehiscence. It was not up to the seat. It was not up to the seat, sir.
Okay. So after second discharge, patient was discharged.
Yes.
Okay. Any comment from any other faculties?
It was not just secondary suturing with a subcutaneous drain to prevent further infection.
Yes. Subcutaneous, yes, sir.
Corrugated
Corrugated
subcutaneous
drain
drain.
was placed. Yes. Put on further.
So you discharged the patient second day. Patient gone home with the drain?
No, sir. Drain removed, sir.
On second day.
Yes.
And what the culture sensitivity showed?
So, growth of streptococci.
No, it was not
sensitive to?
streptococci. It was actually Staph aureus and
Yes.
Sensitive to which drug?
Sensitive to, sir,
Because these are
linezolid.
important. Because in most of the hospitals, you have a different spectra of activity. Okay, so from that you can assess that ways what antibiotic you should start in our setup.
Sensitive to linezolid.
Okay.
Hello.
Yes.
Good morning, Dr. Ankar. This is Dr. Abhishek here.
Yes.
Thank you for the nice presentation. What was the reason of the bilateral inguinal hernia patient being unfit from PSC point of view?
Left ventricular ejection fraction was 28%, sir. So anesthetist didn't give fitness, sir.
So that was the only reason. And what measures were taken to, was he referred to a higher setup or how was he managed?
Yes, sir. Referred to higher center.
You see, the risk will remain same. Even in higher center, the risk will remain same. If the patient is symptomatic of hernia, we can counsel the patient and we can resort to operation under local anesthesia. Okay,
Yes.
so but again, we don't have a cardiac setup here. Patient developing cardiac failure in the post-op period. We have ICU facility, agreed, but we don't have a dedicated cardiac unit. So I think difficult to manage such patients in our setup. But you can always try the patient counseling and others. You can always try that. You can do this patient under local anesthesia.
True, sir. Thank you.
Okay. So the next presentation will be by Dr. Rayas Jain.
Thank you, sir.
Yes, Jain. Okay. So the next presentation will be Unit 2. Dr. Milind Dalogji will present the surgical audit for the Unit 2 general surgery.
Good morning, respected teachers and my fellow postgraduates. I'll be presenting the surgical audit for May under Unit 2 of General Surgery. In summary, we had a total number of 8 OPD days and a total number of 9 admission days. The total number of OPD patients was 847. The number of elective OT days was 9 and the total number of minor OT days were 8. We had a total number of, we had a single mortality during this past month. There were total 42 elective admissions and 21 emergency admissions, 35 elective operations and 16 emergency operations, and there was a single mortality and there was no morbidity. This single mortality was of a single male that was there. The variety elective admissions that were there, we had 6 cases of chronic alveolar cholecystitis who underwent open cholecystectomy. One left solitary thyroid nodule one female who underwent left hemithyroidectomy. There was 1 case of presidentia who underwent posterior mesh rectopexy. 1 case of umbilical hernia who underwent anatomical repair. We had a total of 12 cases of unilateral hernia and 1 case of bilateral hernia. Among the unilateral hernia cases, 8 underwent Lichtenstein mesh hernioplasty and 4 underwent herniorrhaphy, whereas the bilateral hernia patient underwent Stopa repair. There was also a case of ranula in a young female and marsupialization was done. For a giant fibroadenoma, the patient underwent an excision. 2 cases of phimosis who underwent circumcision. Further, there was a case of a neck swelling in the left supraclavicular area, which underwent excision. A squamous cell carcinoma in the left arm, which underwent a wide local excision. The other cases that were admitted in the elective through the elective admissions but were not taken up for any operative intervention included a liver abscess, cellulitis of bilateral lower limb, an appendicular lump, left diabetic foot ulcer, and they were all managed through conservative management. Among emergency admission, we had 1 case of an irreducible inguinal hernia where mesh hernioplasty was done. A case of small bowel obstruction was there where exploratory laparotomy with the visualisis and cecopexy was done. An irreducible incisional hernia was there where again exploratory laparotomy and anatomical repair was done. There were cases of thigh abscess, breast abscess, left sole abscess, and perineal abscess. In all these cases, incision and drainage was done. There was 1 case of a traumatic scrotal hematoma where scrotal exploration and hematoma evacuation was done. Cases that were admitted of polytrauma and head injury were managed conservatively. Acute cholecystitis, 2 patients with acute cholecystitis, 1 male and 1 female were admitted and they were both managed conservatively. 1 female patient with acute pancreatitis was admitted and managed conservatively. 1 patient with a suicidal throat injury was admitted where primary repair of the injury was done and dressing, and patient was managed conservatively. And one patient with the PR bleeding with third-degree hemorrhoids was admitted and was also managed conservatively. Among minor OT cases, the variety of cases that were done included excision of the severe debridement, acute paranoid incision drainage, Zarik's procedure for ingrown tool, and foreign body exploration. Now, we had a single mortality during this past 2 months. This mortality was of a 74-year gentleman who was a known case of type 2 diabetes, hypertension, and with the history of an episode of CVA 10 years back. The patient was admitted on the 13th of May. The patient came to the surgical OPD with a complaint of a large ulcer on the left leg plus foot. The patient was started on antibiotics, analgesics, and conservative management. Local wound debridement was done under sciatic block, followed by regular dressing of the wound. All blood parameters were sent and were in normal limit. Medical management for comorbidities was continued as previously. On 18/5, patient suddenly became unresponsive in the morning. CPR was given, but the patient could not be revived, and the patient succumbed to his the patient succumbed. Thank you, sir.
Okay, go back to the slide of admissions. You see, when you place this admission list, try to make a different groups. So you are writing gallbladder, then thyroid, then come rectal prolapse. Instead of that, you make a standard pro forma.
Okay.
We'll first present, most of our patients are abdominal patients. So we'll take the GI, cholecystitis, gut lesions, and this. Next group of patients are our hernias, some thyroid or some neck swellings. So make a proper heading under which you will present audit for all units. So make a GI, gallbladder, bowel,
Yes,
colorectal, anal, then come to the neck, breast, hernias.
yes.
So, and then miscellaneous.
Okay, sir.
Okay, so make a proper heading so that everyone follows the same format. Next, in emergency, and then go back. Here, because of our OT setup, we take some patient as daycare. So somebody might ask, why do you admit a patient of ganglion right wrist? So this just because of in our OT setup, we take this patient as daycare. So you can make a separate heading for daycare patients. Okay, because these are the patients who are not staying overnight.
Yes.
They are coming, getting admitted, getting surgery done, and then being discharged the same evening. So you can put this as a daycare patient. Next. Is a pain abdomen. You are presenting audit at the end of month.
Yes.
So when the patient is admitted, may not be that patient has got a diagnosis, but on discharge, patient should have some working diagnosis.
Yes.
You have done ultrasound, you have done other X-rays, maybe a CT scan. So in surgical ward, patient should have a working diagnosis. What about the diagnosis? Working diagnosis should be there.
Most of these pain abdomen cases, at least 3 of them, sir, were we found out that they had renal calculus, sir.
Renal calculus.
Yes,
So come to that. So if the pain abdomen is admitted and at the end of month you have some evaluation, and then you should come to diagnose that these are the patient of pain abdomen which is diagnosed later with this, because you may not be able to diagnose on admission.
Yes.
But while discharge, most of the patients had got as a working diagnosis.
Yes.
Okay, next. Minor, then next. Next. Operative list. You have not made a separate operative list.
So, as part of the elective admissions.
No, you make a separate, same with the operative list.
Okay, sir.
So when you make a list of the operations being done, so in the elective operations, you divide abdominal surgery that is being done, neck surgery, hernia, breast, other miscellaneous. So give a outline of the surgery being done.
Okay, sir.
Okay. And then you see, when you operate about 30-40 patients, what is morbidity? Morbidity is when the patient deviates from the road to normal. Even a patient having a stitch abscess is also a morbidity.
Yes.
So one should be very vigilant to find out any morbidity the patient is having. It's no discredit on the part of, you need to discuss what happened in a particular patient, so that you can take lesson from these patients and take care in the subsequent patients.
Yes.
So you don't ignore some patient having ideas for 3, 4, 5 days. You start an IV fluid, patient has vomiting, patient has to be report on IV fluid. So they are all situations which are deviations from the normal recovery. You can always discuss. Okay. And this patient who died following this, you see, this patient was suddenly unresponsive.
Yes, sir.
So a patient who is 74 years is diabetic, one of the important reasons for being unresponsive is hypoglycemia. Have you tested the blood sugar at that
Yes,
point?
sir. We had.
What
we-
was the blood sugar?
So the blood sugar was it was around 98, sir.
98.
Yes, sir. We tested the blood sugar, sir. We immediately tested all the vitals, sir. But the patient was completely unresponsive.
Because what do you feel? What are the important causes of a patient of this age group in the surgical ward has suddenly become unresponsive and is having sudden deaths? What are the important possible situation you start thinking about that?
So hypoglycemia,
You see,
hypotension,
hypoglycemic
sudden
patient does
cardiac
not die so suddenly.
So sudden cardiac arrest, sir.
So some cardiac events,
Yes,
maybe
sir.
acute myocardial infarction.
Yes, sir.
Patient may have massive pulmonary embolism. So these are the situations where patient may have sudden death.
Yes.
So once the patient are there in the ward, if you think that this patient has got a situation which might be pulmonary embolism, then we should take care of this patient. When the patient is in the bed, we should always take care of his limbs. Always exclude that patient has got a mobile limb and then some passive or active exercise.
Yes.
Okay. And this patient who has got a sepsis, this patient has got a large ulcer on the foot. So what antibiotic he was on?
So he was on
You see, diabetic patient, these are mostly
Linezolid,
polymicrobial.
yes.
It can study the
Linezolid.
staph, but deep infection are always polymicrobial infection.
Linezolid
that
and
case,
metrogyl, sir.
So in that case, is a metronidazole may not be adequate. Patient who has got a deep diabetic foot infection is not only to staph, it can be a polymicrobial
Yes,
infection.
sir, we had sent the pus also, but after the debridement, we had sent the pus and all, and so the report was pending, sir. So by the time,
Sir,
sir,
at that point, the wound seemed to be sterile because we had sent the pus, it showed no growth.
Also showing no growth. It may be either sterile or it might be that the antibiotic you prescribed is taking care of this infection. Maybe that antibiotic sensitive
Yes,
infection
yes,
that is
I
cleared up.
mean, he had received antibiotics for around 5-6 days before.
So
he died,
that's what I'm
right, sir?
saying. The patient who was improving suddenly become unresponsive. We should be taking care of the cardiac issues, and most important is thromboembolism. Any comment from any other faculties?
Milind,
Hello?
can you tell more about the small bowel obstruction that you did some cecopexy and what?
Yes, I was that. Yes, small bowel obstruction, cecum is collapsed.
Why
If it is a
cecopexy?
classic small bowel obstruction, the classic description would be a cecum should have been collapsed.
so the patient had a history of total abdominal hysterectomy along with bilateral salpingo-oophorectomy. When we when we did the laparotomy, sir, we found that there were adhesions of the small bowel along the wall.
What is the cause of obstruction here? Is it a band obstruction causing narrowing or kinking at one part of small bowel? The proximal was dilated, distal was collapsed. Did you localize the obstruction here?
Yes, sir. There were adhesions, sir.
Which part? Adhesion, you see, simple adhesion may not cause obstruction. Obstruction means either there is a rotation of the gut around the adhesive component, or there is kinking, or adhesive band is causing a narrowing.
So
What are the cause of
there were
obstruction?
adhesive bands that were causing the narrowing, sir.
Then what was the cecum status? Because in small bowel obstruction, you first go to the cecum. Cecum was dilated or collapsed?
So the cecum was so the cecopexy was done because the cecum was very
Cecopexy
mobile,
next
sir.
part. Cecopexy the next part. The point is, if you say it was a small bowel obstruction, the one important finding in abdomen is the cecum and the large gut should be collapsed. So even if the cecum was mobile, it was not a cecal valvulus.
Yes.
So it's not a cecal valvulus. Adding a cecopexy, you are adding a morbidity to this patient. Because most of the time, if you are doing cecopexy for a dilated large bowel, even then that cecopexy does not work well. If you do a tube cecostomy, most of the time cecostomy tube get blocked. So the purpose of decompressing the cecum with just a tube may not work all the time. And then in case of small bowel obstruction, I don't think adding a cecopexy will, what is the idea of doing cecopexy? Why did you add a cecopexy in this patient?
So the cecum was when we did the visualizes after that after the checking the bowel. So the cecum was excessively mobile, sir. So sir.
So cecum has got a mesentery. Mobile means you mean.
Yes, sir, it was excessively mobile. So we feared, sir, that this might lead to a further problem, sir. So that is why
This can happen, but there is no role for doing a prophylactic cecopexy when the obstruction is small gut. How did you decompress the dilated part of the gut? Most of the time in small bowel obstruction, you have a dilated bowel loops. How do you decompress?
So we,
the best way of decompression is you do a retrograde decompression. Don't make an enterotomy to decompress small gut. So you put a nasogastric tube and gradually milk this content towards the stomach to have a retrograde decompression. Okay, and this should be done very gently, because if you just go forcibly, you can cause multiple serosal tears. Okay, so next time you all arrange the admissions and OT list, you can arrange as per the grouping of the operations, abdominal operations, open gallbladder, lap chole, gastric, colorectal.
Yes.
Okay. Okay. So the next presentation will be by Dr. Nitesh Pradhan, who will present audit for the Unit 3 General Surgery.
Good morning, respected teachers. Good morning, respected teachers. I'm going to present a surgical audit for May 2022 under Unit 3 General Surgery under Professor Dr. Amal Saha sir, Dr. Rahul Naska, Dr. Summary. Total OPD days 7, total admission days 8, total OPD patients were 782. Total number of elective OT days 8. Total time in the OT is 52 hours 45 minutes. Total number of minor OT days 6. Total number of mortalities 3. Audit for May 2022. Total elective admissions were 36. Emergency admissions 9. Elective operation 27. Emergency operation 6. Mortality 3. Morbidity 1. Elective admissions. So chronic calculus cholecystitis, total number were 5, which undergo laparoscopic cholecystectomy, and 4 were open cholecystectomy. Inguinal hernia, total number went undergone hernioplasty, mesh hernioplasty, total number were 4. Cervical lymph node abscess, IND 1 patient, incision and drainage and biopsy sent. CA head of pancreas, palliative care given, patient took LAMA. Left varicocele, Palamo procedure were done. Chronic non-healing wound, debridement was done. Paraumbilical hernia, fitness was not given. Inguinal hernia, TAP procedure were done. Incisional hernia post exploratory laparotomy plus choledocholithesis. Female patient who undergone CVD exploration and mesh hernioplasty. Peptic ulcer disease and chronic calculus cholecystitis. Conservative management was given and the PSC fitness was not given. We have 2 phimosis who undergone circumcision. One female patient with obstructive jaundice undergone given conservative management and for OT. Obstructive jaundice with acute kidney injury, conservative management was given. The USG source for this patient was distal CVD dilatation, but the further investigation could not be done as patient was uncooperative and the urea creatinine level was high. Fibroadenoma left breast enucleation was done. Papillary CA thyroid. Total thyroidectomy was done in the following month. One patient with fistula and nano lift procedure was done. One patient with infective gangrenous toe debridement was done. And one patient with infective gangrenous toe disarticulation were done. One patient with subacute intestinal obstruction, conservative management was given. Appendicular lump, conservative management was given. Patient with cystitis, conservative management was given. One patient with incisional hernia, MS hernioplasty was done. Two patients of fistula and nano fistulectomy was done. Emergency admissions. Patient with acute intestinal obstruction, exploratory laparotomy and resection anastomosis was done. Strangulated incisional hernia with septics of post-open appendicectomy, exploratory laparotomy and stoma creation was done. Gallstone pancreatitis, conservative management, perforative peritonitis, exploratory laparotomy and Graham's patch repair was done. Left-sided pneumothorax post-physical assault, ICD placement and conservative management was given. Anastomotic leak, patient who has gone right hemicolectomy, exploratory laparotomy and stoma creation was done. Left-sided diaphragmatic rupture, post-RTA exploratory laparotomy, plus diaphragm repair and splenography was done. Appendicular lump, conservative management, and patient with multiple lacerated injury, repair was done and conservative management was given. Minor OTs, total 24, including granuloma excision of CBSS, ZX procedure, IND, intraregional transneural injection in ganglion, and papilloma excision. We have one morbidity, female patient, and 3 mortality, male patient. Morbidity 1, 65-year-old lady admitted and diagnosed as a choledocholitis in incisional hernia. She was operated CVD exploration on MS hernioplasty and doing well. Patient was discharged after removal, drain removal, which was less than 50 ml for 3 consecutive days. After 1 week, patient was followed up in OPD with seroma formation. Patient was admitted again and started with conservative management and regular dressing was given. Now patient is discharge is reduced and 10 for discharge. Mortality 1, 40-year-old gentleman was referred from another hospital and was presented at ER with the diagnosis of a strangulated incisional hernia with septic shock with BP 90/60, heart rate 114, saturation was 95%. Patient was resuscitated, but patient was poor responder. Seeing the deteriorating condition, call was taken for emergency laparotomy involving resection of gangrenous bowel and double barrel elastome. Patient was not extubated as he was in severe acidosis and was shifted to ICU in a ventilator support. In ICU, the care was taken to correct acidosis, but patient was deteriorating further and had a massive cardiac arrest after 5 hours of surgery. CPR was given, patient was revived, but had another episode of cardiac arrest and he succumbed to it. Mortality 2, 75-year-old male presented in ER with abdominal distension and constipation with a feature suggestive of small bowel obstruction on X-ray erect abdomen. Patient was resuscitated and was planned exploratory laparotomy. Patient had a terminal ileal growth involving urinary bladder wall. Growth was resected, bladder was repaired, and the resection anastomosis was done. Patient was shifted to ICU. On POD, one patient developed respiratory distress due to side-stated severe pneumonitis and respiratory alkalosis. Patient was nebulized, started with higher possible antibiotic. On POD 5, patient was intubated and succumbed to that on POD 7. Mortality 3, 58-year gentleman who was known case of COPD, presented with right colonic mass and underwent right hemicolectomy. On POD 4, patient was found to have anastomotic leak and was taken for laparotomy, followed by creation of endoleostomy and long Hartmann pouch. Patient was shifted to ICU. Patient developed severe respiratory process and was intubated. And on POD3 post-laparotomy, patient succumbed to death. Thank you.
So we have 3 deaths, and we find there are 2 people are elderly patients and following emergency. The first case, I find patient has got a strangulated hernia.
Yes, sir.
Okay, so patient was having hypotension with a heart rate of 114, and you are saying patient was a poor responder.
Yes.
So patient who is not bleeding, patient has got obstruction. We cannot take this patient for surgery if he is a poor responder. That means we have not been able to optimize the patient pre-op, because you see this patient has deteriorated with anesthesia. He did not came up following reversal, and he died within 5 hours. So in a situation like this, I don't think there is any hurry to rush in. You should take more time to resuscitate these sort of patients. Okay, and then once the patient is optimized, because patient has got a gangrene and patient is in sepsis.
Yes.
So initially you do more vigorous resuscitation, cover the patient with good antibiotics. Because the point that patient is a poor responder stands when the patient is bleeding. If the patient is bleeding continuously and you cannot resuscitate the patient, there is a role for going for early surgery. But patient with obstruction has to be optimized to at least withstand the stress of anesthesia and surgery. Okay, but I think this sort of patient should be, you see, he's a 40-year-old gentleman.
Yes.
So he is not an elderly patient. So the other patient who can be, you see, patient who has got such situation, strangulated hernia, is in severe volume loss.
Yes, sir.
Patient is in shock, patient is in sepsis. So you have to take care of all these. A delaying surgery by another 6 hours or already strangulated may not be further deteriorating the patient, rather than you are taking care of the deterioration. Any comment from any other faculties?
Hello.
Yes.
Yes, sir.
Good morning, Nitish. Dr. Abhishek here. What tests, any tests that you had done to ascertain the cardiac status of the patient, of this particular patient?
Sir, cardiac status, sir, on like 2D echocardiography was not done, sir, at that time.
ECG you did? ECG?
Yes, sir. ECG.
How was ECG?
Sir, ECG, sir, it shows tachycardia, sir, and
You see, 40-year-old gentleman, you don't expect to have cardiac issues here.
Mhm.
But doing a echo in this setup is difficult in emergency.
True, sir.
Hmm.
Also,
so patient came early morning, sir. We like trying to resuscitate, and we have taken after 4 hours when he was.
No, that's what I'm saying. The point you are mentioning, a patient is a poor responder. I mean that the patient has not been adequately resuscitated. You have done a central line for this patient.
Yes, sir.
How was the CBP? These are all important. You see, once you stamp the patient is a poor responder, we have to ensure that we have done a proper monitoring. Suppose you have to put a CBP line. You find, yes, CBP has come up. Okay,
Yes.
you have done a total count. The total count is high, and you have given the patient the best available antibiotic as an empirical antibiotic. So that point I'm saying, patient who is a poor responder having an obstruction, we can still wait for some more hours to optimize the patient, but not for bleeding. Yes, Ganesh.
This patient was initially admitted in a PHC for 2 days for abdominal pain. Then the patient referred to assisting hospital for 1 day, where he couldn't get the bed and everything. Then they sent the patient after 3 days of obstruction transit.
That's what I'm saying. The patient has been to some facility where he was not taken care of. And once he come up to our place and we find he is in so severe shock, we cannot take the patient to operation table without optimizing him. You said he is a poor responder, and seeing this, he is taken to the theater. But with this poor responder, you take the theater, he will not withstand the surgery. He will not withstand the anesthesia. They could not extubate the patient. They couldn't extubate the patient. Within 5 hours, he has died. That means this patient was optimized. This is only applicable, as I say, when the patient is bleeding. When the patient is bleeding, the idea is to stop the bleeding, and most of the patients respond. If you can do a surgery and stop the bleeding, most of the patients easily improves. But this patient has got a compromised status on number of sites, means volume deficit, maybe electrolyte imbalance, maybe he has got hemoglobin issues, maybe he has got systemic sepsis, maybe he has got some pulmonary issues also. So all this has to be optimized. Next modality. You see, this patient died of pure respiratory complications. And these are the time when you start developing immediate, is an elderly gentleman. So we should be vigilant in elderly gentlemen undergoing abdominal surgery, that as early as first post-op day, this patient can develop pulmonary complications. And a elderly patient develop pulmonary complications, even if put in ventilator, is bound to have deterioration of this respiratory complications. So the lesson is here, for any elderly patient, we should take care of his limbs to prevent DVT. We should take care of this chest, so that he takes deep breathing with chest physiotherapy, because these complications of atelectasis and other pulmonary complications come as early as immediate 6 hours to first post-op day. So this can develop very fast. And probably he was confined to bed earlier also. So this part has to be taken care of. You see, this patient probably did not have a anastomotic leak because we did a diversion and the Hartmann's closure. That decision was good. In an elderly patient of this situation, you could have done also a externalization. Hartmann's reversal is a difficult surgery. So in this situation, you could have brought both the loops side by side. That is equally acceptable. Okay, Dr. Abhishek, any comment? Siddharth, any comment?
No.
I just have a comment, sir. Why was, a patient came in emergency, we could have just, what was the condition of the patient?
He was initially, I thought this is the second admission. The same patient, who was admitted earlier, he discharged him. Yes.
Yes, sir.
Actually, this
Was the
patient
second
was
admission.
admitted earlier. We had a diagnosis of bowel obstruction. We did a colonoscopy, nothing was found. And we thought he has got some bowel obstruction. He was relieved. He was discharged home. He was readmitted with features of acute small bowel obstruction. So this time they decided to proceed with laparotomy because he has got abdominal distension and all classic features small bowel obstruction. And then on laparotomy, they could find a growth near the terminal ileum. Because you see, colonoscopy was normal because the growth was not in the up to cecum and distal terminal ileum. The decision for laparotomy was all right in this patient because second admission with obstruction, there is no role for continuing the conservative treatment.
No, laparotomy is fine, sir. I just want to know if we could have gone without the resection of the tumor, just a diversion. If the patient was not well, it would have taken lot less time.
That's true, but you see, if you could do a resection, that is the best you can do in the emergency setup. And they have rightly has not done a anastomosis. They have not taken more time to do anastomosis. They just do a diversion. So that is an acceptable procedure.
Nitesh,
A diversion in this sort means what? He has got a terminal ileal growth. Okay.
Yes,
so
yes.
You may not do a standard resection. You can just do a resection and do a stoma. That's it.
Yes, sir.
Nitesh, how was the ABG and chest X-ray of the patient pre-op?
Chest X-ray was clear for that 75-year-old patient. Post-operatively on POD1, the chest X-ray was done. It shows right-sided complete whitening of the lungs.
Pre-op ABG. I was asking for pre-op ABG. Had you done a pre-op ABG?
Pre-op ABG was not done.
Okay.
This is a patient. Actually, this patient was GC was poor and he underwent right hematolectomy. The more important point in this situation is, you see, this anastomotic leak can occur as early as 24, 48 hours, 72 hours. So these are the patient who deteriorate very fast because of sepsis. So this patient has got a leak, and this leak was detected little late. And this patient, although underwent a ileostomy and a distal part was closed, but this patient succumbed because of systemic sepsis and some pulmonary issues. So the other situation, we should be more vigilant to detect a anastomotic leak. These are very important. The anastomotic leak which are detected early can be managed well.
This patient had a liver met, single liver mets.
That you should mention. This patient has got an advanced disease. This patient has got a liver metastasis, and his GC was also poor. So these are the situation where we could have avoided doing a primary anastomosis, but we decided to just do a standard hemicolectomy. I mean, it's not a radical hemicolectomy in view of the liver metastasis, but this patient has some situation that there might have been some anastomotic leak, but we took a chance. Anyone from other district hospitals in the class? Any DND PGT from other district hospitals? Anybody in the class? Howrah, Imambada, anybody? No. All are senior people. Madam, any comment regarding our audit? I find there are a lot of OPD attendance in MR Bangalore. Each unit is seeing almost around 800 patients in a month. So that is a good number. I think this number also will increase in coming days. So literally busy units. Madam, any last minute comment? We'll close.
Sir, I just wanted to know something, that
Yes.
when we are talking of a clinical audit and mortality discussions,
Yes.
as Dr. Abhishek and I couldn't get the name of the other person, they were asking questions. The purpose is the patients can die. They come in a very bad situation in government hospitals. The purpose of a mortality meeting is what could we have done so that this patient could have saved.
Yeah. That is the idea.
So
That's what I mean
that
to
is
say.
more important, because what as teachers we try to do is we try to give explanations for what is the situation in our hospitals or what are the limitations of our hospital. So that should not be the point of discussion. Like Dr. Abhishek was asking about, probably I heard that he was asking about ABG. So ABG could not be done, but will ABG being done preoperatively help the patient? So that is the question which has to be answered in such meetings. And
Yeah, actually, my
really
idea
it
is
would
that
be,
only. My idea is to analyze. We don't have postmortem.
yeah,
We don't
right,
know the
sir,
exact
right,
cause of death in this patient.
right. So we know that the patient
what
has
we are
died
doing
now.
is, yeah,
So
we are just
now
analyzing the clinical sequence and what we could, as I said, the second patient who died of pulmonary complications. From now on, we should be more vigilant that elderly patient, you take care of the lower limbs, active movements, you take care of chest physiotherapy. So that should be done starting for admission time.
right,
Because the lung complications can come up very fast.
can occur in our patients, especially when they are coming in such a bad situation. So, like I heard a question that why was preoperative CT done in that patient? So, if it was done, then did they not find out the ileal growth what we were talking of?
Actually, madam, this patient had a CT done earlier in the first admission. This
Yeah, that
CT
was
could
an
not find
obstruction,
this.
you said.
CT could not localize that growth in the ileum. So
That
that's why we
growth in the
discharged the
ileum.
patient for
Because
review in the OPD.
Eminently, sir, the ileum problems are difficult to assess preoperatively, right? Because we don't have any other tool in our hand.
Yeah.
So,
Next tool should have been a capsule endoscopy or a
yeah, that's what I'm saying. Or an enteroscopy, MRI enteroscopy. Yeah. So that is what I was fine. Otherwise, so your boys are doing a great job. They are keeping even me busy every day. So it's good, sir. That's
No,
good.
actually, this is part
So-
of DNB program. I find the
Yes,
national
I know that, sir, because it
in
happens in
national
our
board, they
college
put
also.
a topic that every center should have their audit being discussed, because this is important.
Yeah.
If you discuss the audit, you learn
Mm.
what is happening in your setup and what are the lacunae, how you can improve your activities. So that is the idea of
Yeah.
doing the audit. So I am
Yeah,
trying
just
to
in-
have this audit in other district hospitals, but you see the participation is not very good. I don't find other faculties joining in the class, but I'm trying to have a liaison with these people so that you can have an idea of what, suppose this Bangalore is a district hospital. So if the
Mhm.
Bangalore can treat 800 patients per unit in one setup, and you see the admissions also not very less. Each unit is
Yeah.
admitting around 50 patients per month. And so just a reflection how other, maybe that other districts are more busy. If you go to the periphery, you'll find the other districts are more busy. They have more workload. So these are the objective way of assessing what is happening in our setup. Thank you, madam. So we call it a day. We again join on next Friday.
Right, sir, because I try to attend your classes. First of all, what is
Yes,
what is
madam.
required
Yes.
by DNP. And second is if my college is doing my college is also doing an audit. So what extra can be done in our college? That is the only purpose I try to attend your classes. So it's good, sir. Thank you for this.
No, actually,
Thanks a
even
lot.
madam, your students are DNB students. One day I can your audit can be a comprehensive audit. What is the surgical audit in your center? We learn something from that also.
Yes, sir.
So if you
Okay.
communicate, we can have a space for these people also. We can
Okay,
choose time
sir.
for
Okay,
these
sir.
people. Okay. Thank you, ma'am. Thank you.
Thank you, sir. Thank you.
Thank you.